Welcome to Chapter 14. I'm going to be talking about shock today. This is a overview of shock and the different kinds of shock. We'll dig into each separate type as it's appropriate, working our way through the various organ systems. We've already hit on respiratory a little bit, but now we're going to put it into the broader context and discuss what shock is, how it happens, why it's bad, and what we're going to do about it. So that said, let's get started. So our goals over this lecture are for you to be able to identify shock and perform basic resuscitative steps for the various types of shock to prevent respiratory or cardiac failure, and then what to do if a patient is in cardiopulmonary arrest secondary to their shock state. And then it's crucial, again, this is the advanced level, so you guys are responsible for a much more complex understanding of the pathophysiology of the various types of shock. This is meant to be foundational for paramedic, or if you're going to go on to nursing, or whatever your next steps might be. This is going to lay the groundwork so that you're not trying to learn advanced physiology and advanced treatment at the same time at the next level. This will also make you able to participate in the treatment decision-making process alongside your paramedic and understand the goals of the treatments being rendered to your patient. So what is shock? There's several sort of simplified definitions. The one that I like the best is it's a state of collapse and failure of the cardiovascular system to deliver oxygen to and remove waste from cells. There's a few things to unpack here, right? It is a state of collapse, and that state is important, right? Because it is an overall condition that the body is in. It is not always one specific thing. Sometimes it's multifaceted, multifactorial, but it is the state that everybody gets in right before the end. The 1 foot in the grave, the you look terrible, that is shock. When you can look at a patient and think, uh-oh, that is a shock patient. They're in a state of collapse. And it's ultimately the failure of the cardiovascular system to deliver oxygen and remove waste. So you can see there's a couple components here. So we've got the heart, the vascular system, and then we have to get oxygen and we have to be able to remove waste, right? So oxygen removing waste involves the lungs, and cardiovascular is the heart and the blood vessels. So you can start to see where having an issue with any one or any combination of those things for whatever reason can precipitate a shock state. So I want you to see all the pieces that go into this so you have a framework as we move through the rest of this. So as we get closer and closer to that shock state, your body attempts to maintain homeostasis. That just means compensation, right? So we're going to talk about the different compensatory mechanisms. We've hit on some of them before, but that's where we're going to target things, with either our pharmacology or our airway management or our cardiac support. The body tries to do that early on and will continue right up until the end trying to fight it. And it's when the body can't compensate anymore that the shock becomes irreversible, and arrest and death soon follows. And that's the difference between compensated and uncompensated is delineated by when homeostasis is no longer maintainable despite the best compensatory efforts. You get a slowing of circulation that eventually ceases, and that is the arrest and death. So lots of things can cause shocks. I know you all have probably heard of shock trauma at the med. Not all shock is traumatic shock. There's certainly a wide array of medical shocks. That's what we're going to get into. And any presentation can result in shock if you don't watch it closely enough. So this is the thing that EMS being able to rapidly identify and treat is what makes the difference for our patients, because a true shock patient, is going to remain alive, on the order of minutes, hours at most. So by the time you see them in those late stages, what you do will make a difference for that patient. So it is vital that you're able to rapidly identify it, know what's happening physiologically, and how to correct it as quickly as possible. So again, to know what's abnormal, we first have to have a grasp of what's normal for our patient. So definitions wise, we're going to talk a lot about perfusion and what is adequate and inadequate perfusion, right? So we've talked about how to identify adequate and inadequate breathing, adequate, inadequate respiration, both external, and now we're going to be getting into the internal side of that respiration. In order for respiration to happen at the cellular level, right? That's the oxygen into the cells and CO2 coming out, in the capillary beds at the end organs. There needs to be perfusion, right? So we have to have perfusion in order for cellular respiration to take place. So perfusion, simply put, is the circulation of blood within an organ or a tissue, and it needs to be in an adequate amount for us to say that an organ is perfused. So what goes into perfusion? All right, so we know that our heart is the pump. So if we're going to have adequate blood flow, we have to have a functioning pump. And then how do we talk about how well our pump is functioning? That's going to be our cardiac output. So it's going to be our metric for pump function. And we measure that in terms of liters per minute. And how can we calculate how much blood our heart pumps every minute? So we need to know, what the stroke volume is, right? So how much fills each ventricle. Stroke volume. Sorry, my K was starting to be an X because I was thinking ahead. Stroke volume times the heart rate equals the cardiac output, right? So the stroke volume is how much blood gets pumped out per beat, and you multiply that by the total number of beats per minute, and that's going to give you your volume over a minute. So that should be fairly intuitive, right? It's the same if you think about your minute ventilation, right? It's your tidal volume times your respiratory rate. This is the same thing, but on the heart side of things. So what goes into this stroke volume? So stroke volume can get broken down into, how much goes into the heart, right? So the filling pressure, and that's going to be a function of our preload. And what does it have to work against? So that's going to be our afterload, is the resistance to flow. And then how hard is the heart able to squeeze out the blood that it gets filled with? And that's going to be our contractility, right? So you can see like these are all going to be sources for shock or states of emergency for our patient, right? There's either not enough filling, the heart is not able to beat strongly enough, or there's too much resistance to get blood out, or there's too little resistance to generate flow. So these are all areas where patients can have emergent conditions that left untreated can result in a shock state. So just a quick review. I already mentioned cardiac output is the heart rate times the stroke volume. So your blood pressure is what the heart is pumping out times the resistance in the blood vessel. So for my fire guys in here, the way to think about that is, imagine that you've got your water flowing through a line, right? If you have a big, huge line, when you're like a big 4-inch main, you're going to have a certain amount of pressure in there coming off the pump. If you don't change the pump that you're using, right, you keep the output the same on the pump and you hook up to, a 1-inch or a 2-inch line, that pressure is going to shoot up through the roof because you're going through a smaller line. There's more resistance to flow in that line. Or the nozzle that you're using does the same thing, right? If you open the nozzle all the way, you get high flow coming out and there's very little resistance. But if you start to close that nozzle, you get much more pressure coming out of the end because there's higher resistance. So when we talk about what is somebody's blood pressure, what we're looking at is a function of the flow coming out of the heart as well as the resistance in the vasculature. And those two things together are going to influence what a patient's blood pressure is. So now that you all are big boys and girls, when we talk about shock, systolic and diastolic are important, but what we use more is the map. I'm interested in the average pressure in the blood vessels. And you can use this formula here. I like the one I'm about to write on the screen a little bit better. It's the exact same thing. The math works out to be the same. But I like 2 times the diastolic plus the systolic over 3. So this is just a weighted average of the systolic and the diastolic, where we're counting the diastolic twice. And the reason for that is the heart spends, at relatively normal heart rates, you spend on average about twice as long in diastole as you do in systole, right? Contraction is relatively quick, and then there's a pause, while the heart repolarizes and refills in between beats. So we spend about twice as long in diastole as we do in systole, so we weight the diastolic pressure more. So if we take, just to give you guys an example, so let's take 120 over 80 for our blood pressure. To figure out the map, what you would do is 2 times 80 plus 120. Oh, yep. And then we're going to divide that by 3, which works out to just about 93. So the map for the textbook normal blood pressure would be 93. because you're going to get 160 plus 120 is 280, and then 280 divided by 3, about 93. And it takes on the order of about a map of 65 or so to adequately perfuse the vital organs at a bare minimum. So 60 to 65 is considered normal. So anything above 60 to 65 and you're in business. So how does your body regulate MAP? How does it adjust its blood pressure? So we go back to the blood pressure equation, and we said that BP is equal to the cardiac output times the systemic vascular resistance, right? The resistance from the system times your cardiac output is going to tell you what your blood pressure is. So, your body can either adjust the cardiac output or it can adjust the resistance. Those are the two things we target with medications as well, by hijacking your body's autonomic inputs to that system. So in the farm lecture we talked about what the autonomic system is and where it goes. So this should largely be review, but you've got the centers in your brain stem, the medulla oblongata. Again, that's where our respiratory centers are. It's also where the control of our cardiovascular system originates. And you've got the two arms of the autonomic nervous system. You've got the sympathetic and the parasympathetic. Right? Sympathetic is going to be fight, or flight. So this is going to prioritize, muscle activity, cardiac output, increased respiratory function, right? So this is going to be heart rate up, blood pressure up, bronchial is going to be dilated. You're going to get blood flow away from your core and to your muscles. And then parasympathetic is our rest and digest. So this is going to be blood to the core, slower heart rate, decreased cardiac output. So that's the two regulatory mechanisms that the body has at its disposal. So these two pictures are meant to show you, what happens to the body under each branch of the autonomic nervous system. So over here, our sympathetic system, and over here, we have our parasympathetic. So under high sympathetic signaling, you get dilated pupils, you get arterial constriction, right? Because that's going to increase our systemic vascular resistance. That's going to raise the blood pressure. You get bronchial muscle relaxation. That's going to allow better airflow, better oxygenation. You're going to get slowing of the GI tract because that's your body's not going to want to burn energy on digestion at this point in time. Then your heart is going to beat faster. It's going to squeeze harder, and it's going to be more apt to conduct electrical signals. So the signals are going to get transduced faster, and the heart will reset faster under sympathetic signaling. Parasympathetic response, you're going to get the exact opposite, right? So you're going to get constricted pupils, increased GI tract activity. Your body's going to be willing to expend more energy on gut activity, slower heart rate, less force of contraction. There's no direct effect necessarily on the lungs. It's not like you're going to get bronchoconstriction with parasympathetic tone, but they'll return to the resting state, which is a slightly constricted state, and in an exacerbation of this, right? If somebody is exposed to like nerve agents, exacerbate parasympathetic responses and signaling, you end up with the excess mucus production, and the arterial, there's not active dilation under parasympathetic signaling. However, when there's excessive parasympathetic signaling, it blocks the body's baseline signals to maintain vascular pressure, right? So the vessels are allowed to relax. So this is a little bit of a misnomer here. Take it with a grain of salt, because again, it's not going to actively dilate them, but it prevents them from remaining constricted and maintaining pressure appropriately, which is, when you talk about somebody vagaling down, having a vasovagal response and passing out, you see this a lot in old people. It's the body stops sending the, hey, let's keep a good pressure in here signals, and they end up dumping their blood pressure because of that. So sympathetic, parasympathetic, just very broad strokes, what's happening in the body with each of those. So we're going to focus in a little bit on what exactly those signals are doing. So at the vascular level, the sympathetic system causes smooth muscle contraction, right? So you end up getting, if you think about what a sphincter is, right? Talk about the gastric sphincter, the pyloric sphincter, the things that they're the rings of muscle that keep things in your stomach, when stuff's supposed to be in there, and then allow stuff to pass through, again, when it's appropriate, right? The smooth muscle that lines your arterioles function just like sphincters, and that they can regulate how much is allowed to pass through them. And you've got the actual the walls of the capillaries themselves are just one cell thick, but how tightly those cells are adhered to each other, is also sensitive to this signaling. So the sympathetic system tells everybody to, hey, tighten up. We need to increase our pressure. We want to increase the flow. And then the parasympathetic system says, all right, you can back off of that signaling right now. And then at a more local level, there's chemical signaling that happens. So we'll talk about, inflammatory signaling, cytokine signaling came up in the pathophysiology lecture at the start of this course. So there's chemicals that get, secreted by cells undergoing an immune response or a stress response that induce inflammation. And what that is a product of is those gaps between the capillary cells becoming loose and allowing fluid to leak out, and then opening the arterial vessels near the site to allow more blood to come into the area, but under a lower pressure. So you get more delivery but less flow, and then all that extra leaks out into the space surrounding the injured or sick tissue. And that becomes important later when we talk about things like septic shock or distributive shocks. So maintaining perfusion is a balance between the heart's output as well as the state of the vascular system. And then just because the blood is going around and around effectively, it still requires oxygen to be delivered to that blood, and we need to be able to get the oxygen, out of the alveoli into the blood, and then out of the blood into the end organ, the end tissues appropriately. And then we also need to be able to get CO2 back to the lungs, released to the alveoli, and then sent to the outside world. So in order to avoid a shock state, you have to have both arms of this system working. Your heart has to be working, your vascular system has to be working, and then your pulmonary system has to be able to manage the gases that the cardiovascular system is shipping and receiving. And it's really important, and this is just an opportunity to review our acid base here. We don't have CO2 bubbles in our blood, right? Your cells produce CO2 when they burn the glucose for energy, but then it is immediately dissolved in water, and that gives us our carbonic acid. HCO3 minus, right? So your cells produce CO2 when they undergo cellular respiration, but it is immediately dissolved into the water, which gives us carbonic acid. And this is what floats around in our blood. This is where the carbon dioxide is hidden until it gets to the lungs when it breaks apart back into water and CO2, right? This is what we breathe out. When we take a breath out, right? We're breathing out water and we're breathing out CO2, but it gets transported through the body like this. And then the metabolic end of the equation lives over here. And sort of more on that to come. But this is what gets circulated, and this is what gets released at the lungs. So what can cause a shock state? So you can have pump failure, right? If the cardiac output is not sufficient, you've got pump failure. You can have blood vessels that are so dilated that there's not enough resistance in them in order to get flow. And this can be a confusing concept for some, but I like to use the fire analogies whenever possible. So let's go back to, imagine you've got a fire hydrant, right? And your hydrant is a couple 100 feet from your house, right? If you just open the hydrant and don't put a hose on it, you're going to lose all of that pressure coming off, right? Even if the pumper is parked, 50, 60 feet away, that water from the hydrant will never be able to flow into the pump effectively, right? You have to put a hose on it, and the bigger the hose is, the less pressure is going to be coming through it into the pump, but you have to have some level of resistance. You have to have some manner of a hose, something to guide that flow. And I know that we don't have, 1 foot mains to put on a hydrant, but for the sake of argument, let's say that you did, right? You hooked up a 1 foot wide pipe off of your hydrant, you wouldn't have enough flow going into your pump at the other end versus, you hook up a 4-inch main. I think that's what goes onto the hydrant, and I'm not fire, but you all can see that the smaller the line is, the more pressure is going to come out the other end. Obviously, you can get too small and you're not going to get enough flow, but you do need to have a small enough hose or a small enough pipe to generate meaningful amounts of pressure. So if you don't have enough pressure in the vasculature, you're not going to get sufficient flow. You can have inadequate oxygen carrying, right? So let's say you've got a good pump, you've got good vasculature, but you don't have enough cells to transport the oxygen around. That's going to result in a shock state. And then what does the body do when any of those things happen? Well, it says, I'm going to take away from the organs that don't really need the oxygen, right? So it'll start with the skin, especially in your periphery. It says, well, we're just going to stop delivering blood to that and try to give more blood to the organs that really need it. The brain, the heart, the kidneys, the liver, which will work transiently, right? But even if you do get effective delivery to the vital organs, your skin in your periphery and all the muscles are now going to be in a shock state because they're not getting blood. So it's, it's a finger in the dam, but it is not, unless you reverse what is causing that shock state, that's not sustainable, and it'll only end up creating more shock on down the road. So that's why compensation sort of goes in stages, and if you don't reverse the initial cause of the shock, your patient will move into uncompensated and then irreversible shock states, potentially culminating in an arrest. All right, so this picture is going to get used a lot as we go through the rest of this lecture. So you've got your heart here in the middle, and this is just diagramming the pulmonary circulation, which is over here and over here, right? Blood comes right atrium, right ventricle, pulmonary artery, goes down the pulmonary arteries, into the lungs, picks up oxygen, comes back through the pulmonary veins, into the left atrium, left ventricle, up the aorta, right? So up here is all your upper body, and then your aorta comes down, loops behind the heart. Then this is just schematically the rest of your body. So when we talk about where shock can happen, I'm going to refer back to this image a lot to discuss where the problems are and why they are a problem. So 3 things that we need in order to have adequate perfusion, right? You have to have a good pump. That's our heart. You have to have an effective medium for transporting oxygen and transporting waste products. That's our blood. Then you have to have an adequate system for getting that blood to and from the pump, the lungs, and the end organs. And so that's going to be our vasculature, or you'll hear it referred to as the container. Right? So you have to have a pump, you have to have fluid, and you have to have a container to circulate it all in. And those 3 things together are known as the perfusion triangle. Right? So damage to the pump through things like disease, heart attack, trauma can decrease the output from the pump. Loss of blood or a problem with the oxygen carrying capacity of the blood can result in shock, or massive dilation or overconstriction of the vessels can result in under delivery of oxygen and under clearing of waste. And we'll talk more about both the over and the under constriction of those vessels when we get into the specific types of shock. So there's a whole section on cardiogenic shock or pump failure coming up. So for right now, we've got to talk about the blood and the vasculature before we get into the specific types of shock, including pump failure, cardiogenic shock. So a little bit on the blood. It is how the body both carries oxygen and nutrients to the cells. It's also how we get the CO2 back to the lungs. So we have to have enough circulating blood volume with enough functional blood cells in order for us to avoid going into shock. So components of our blood, you've got the red blood cells, white blood cells, platelets, and plasma are the major players here. I will want to add there are some blood proteins. If you think back to the respiratory lecture, we talked about pulmonary edema. Again, that's going to come back in this lecture as well. So tack those guys on. And what's important to know here is your RBCs and your plasma are where the O2 lives, right? So your RBCs can carry 4 oxygens each, and that's what our SpO2 monitor is detecting, right? How saturated are your red blood cells with oxygen, right? So that gives us our SpO2. And then the plasma is actually where we're measuring that PaO2 that you all have seen in the respiratory chapter in the context of the blood gases and the metabolic. When we're talking about oxygen delivery and looking at oxygen actually in a blood gas. And, these two are proxy measures for each other. There is a relationship between the 2 numbers, and you guys will learn all about that in paramedic school. But it's the O2 that is actually diffusing into the tissues themselves when we're delivering oxygen is diffusing out of the plasma, but it's the RBCs that are responsible for making sure that concentration, that gradient is maintained in the plasma. So that's why we have to have an appropriate volume as well as an appropriate amount of RBCs, right? So if we just fill somebody up with saline, we'll expand the plasma volume, which is great, except it can't carry oxygen. And if we, dump somebody with just red blood cells and no fluid, they're not going to be able to circulate, and we're not going to be able to maintain the right gradient between the plasma and the cells. So we got to have both. And the third part of the blood we have to understand is blood clots, and that'll come up when we talk about cardiogenic shock as well as some obstructive shocks. Is how do we end up with blood clots that cause us issues? So obviously blood clots are good when they stop us from bleeding out, but they can become pathologic when they form in places where we don't want them, or when we don't need them, or where they're not normally needed. So, our body constantly undergoes micro injuries, right? Our blood vessels have normal wear and tear just like anything else. And there's a little blood clot that forms, the vessel heals itself, and then the body breaks down its own clots, and there's no problem. What ends up happening, though, is certain people are predisposed to either increased incidence of vascular injury, and those are going to be your diabetics and your hypertensive patients, where there's direct damage to the vascular walls due to their underlying disease state. And then people who are extremely sedentary, so that could be you're overweight, you're elderly, you're otherwise bedbound, or the classic, somebody who's on a long airplane trip and doesn't get up and stretch and move around a little bit. So you can have retention in blood, damage to blood vessels, and that leaves somebody very vulnerable to forming a clot. And if the injured area is big enough or the blood is static enough, that clot can become pathologic and can grow so large that it can either occlude right where it's at, or it risks breaking off a piece that then travels and lodges somewhere else undesirable. So now we're going to talk about the containers, our blood vessels. So how does that autonomic nervous system compensate when there's a problem? So it can sense falling blood pressure through a variety of mechanisms. There's stretch receptors and chemoreceptors that are sensitive to changes in pressure and changes in either delivery of nutrients coming in, or waste products building up. Remember the chemoreceptors in your respiratory center in your medulla that regulate your breathing by sensing the pH of the CSF and giving us the hypercarbic drive. So when these mechanisms are tripped or triggered for falling pressure or decreased nutrient delivery, the sympathetic nervous system kicks in and says we need to bring in more oxygen, we need to more effectively deliver nutrients, and we need to ensure that we're delivering to the most vital structures first. And then the parasympathetic nervous system is what's constantly running in the background. So we see it, we call it the parasympathetic tone, when there's no sympathetic signaling happening, or when there's decreased sympathetic signaling, we start to see the parasympathetic running in the background. Then it can upregulate when we eat and when we sleep, but when we're awake going about our day, it runs in the background, and then the sympathetic system modulates how much of its activity we see. So when somebody's going into shock, we're going to see profound sympathetic responses. So the couple receptors, I mentioned the baroreceptors. Baro, if you think barometer, means pressure. So you actually have pressure receptors. The most prominent ones are going to be, so you have your aortic arch here, and you've got 3 branches off of your aortic arch. I am not at all an artist. All right, so if we call that our aortic arch right there, there are baroreceptors embedded right here. So if our blood is getting ejected out of the left ventricle right here, the harder it comes out, the more those stretch. And that tells your brain that, hey, there's sufficient pressure in the vessel. So as your blood pressure starts to fall or the heart starts to fail and you get decreased flow coming out of here, those are not stretched nearly as much with each beat. And you get signaling saying, hey, there's a problem. We're not getting enough pressure in the main, the big vessel right off the heart. So if you've got poor pressure there, it follows that there's poor pressure literally everywhere else. And then chemoreceptors, you all are familiar with, sensitive to, amongst other things, pH, which can regulate our respiratory drive. And typically, you start seeing some pretty profound stimulation of these baroreceptors whenever the systolic is between 60 and 80. And it's reasonable that when your systolic is 80 or below, you should definitely be seeing a properly functioning autonomic nervous system. You should definitely be seeing some of these sympathetic changes. And a patient whose systolic is 60 should be at about maximal stimulation from that sympathetic system. So those are going to be your patients that are cold to the touch peripherally, one, because they're not cycling blood, two, they're dumping epinephrine and norepinephrine to try to stay alive, and that's causing peripheral vasoconstriction. So that's when we talk about heart failure. When you have a heart failure patient who's cold in their extremities, that's really bad because they're at the end of the road. They're going to have big, giant pupils. They're going to be breathing quickly. Those are all maximal compensation, signs of maximal compensation that will be occurring at that 60 range in the blood pressures. So when there is hypoperfusion, what are some of the other mechanisms that we get? It's not just, vascular clamping down. There's other systems that get activated. So your kidneys are sensitive to the amount of blood running through them. We call it the GFR, glomerular filtration rate. So when your kidneys are seeing decreased flow through them, they start excreting a protein known as renin, and that sets off this renin, angiotensin, aldosterone system that culminates in your brain dumping something called antidiuretic hormone, which if you've ever been in the hospital or been on a critical care truck and somebody's getting a vasopressin infusion, or you've heard the drug desmopressin, that is the antidiuretic hormone. And as the name would suggest, right, a diuretic is something that causes people to urinate. So an antidiuretic is something that causes people to retain fluid in the vascular space. So that's one of the body's other compensation mechanisms that it has, is to trigger renin, angiotensin, aldosterone system. You'll sometimes see that abbreviated as the RAS, which results in increased vasopressin that causes the body to retain water. So obviously your kidneys getting involved is late, and I told you that you're not going to see that profound peripheral vasoconstriction until later stages. So the early response, right, the first thing we're going to see is cardiac. So your heart has sympathetic nerves running to it, and it's the easiest thing for your body to do is to upregulate your cardiac system. So it can say you need to beat harder, right? You need to beat faster. So stroke volume is going to be harder, pulse rate is going to be faster. Then the increased preload is going to be a combination of things. We'll talk about preload and afterload here in just a minute, but through things like vasoconstriction and fluid retention, the body can increase the amount of fluid coming back to the heart, right? And if you fill it up with more, you'll get more out of it. So cardiac compensation comes early on. So tachycardia should always be taken seriously in a patient who you have concern about either being in shock or potentially becoming a shock patient. There's a metric, we use it mostly in trauma, but something called the shock index. And what that is it's your heart rate over your systolic blood pressure. And if that is greater than or equal to 0.9, that's bad news. So, in other words, if your heart rate is either close to or higher than your systolic blood pressure, your patient is in pretty rough shape. So what that would look like is, let's say you've got a patient who, they're a little pale, they're obviously not feeling well, and you grab some vitals and you see that their heart rate is, 108, and you're like, all right, well, that's not terrible. It's cause for concern, and it's definitely tachycardia. So then you grab a blood pressure, and your blood pressure comes back systolic of 100, right? That's going to be greater than 1 because 108 is bigger than 100. So that is a high shock index patient. Now, you're not going to see that on any test. That is just a clinical pearl, little nugget when you're trying to figure out how sick somebody is. Now you understand the physiology of what's happening there, right? That blood pressure has dropped to the point that their brain is telling the heart rate, hey, you need to pick up some slack here. And the fact that the heart rate is now higher than the blood pressure is telling you that we're running out of runway on this compensation. And then the concept of auto transfusion, is not that they're leaking their own blood and you're putting it back in. That is also called auto transfusion, and we do that in like shock trauma patients that are actively bleeding out. But in this case, it's the concept of constricting your peripheral vasculature so much that you're essentially pushing all of that fluid back into your core. So you're delivering your vital organs excessive volume of blood by depriving your peripheral vasculature of it. So if you were to lose 25% of your blood volume instantaneously, your peripheral would clamp down, your arms would get real ashen and cold and numb, but you would be able to stay alive and survive that because all of your vital organs are going to remain adequately perfused due to this concept of auto transfusion that's brought on by vasoconstriction. So what happens when we do run out of runway on the compensation and the body remains hypoperfused or underperfused? So poor systemic circulation means that there's going to be less blood coming back to the heart. We're going to talk about that in just a minute, but the net effect of that is you have decreased preload. Your tissues are going to continue to be underperfused, which is going to result in the accumulation of even more waste products and metabolic acids. The fluid is going to continue to leak out of your blood vessels. They're going to continue to dilate as waste products build up, right? So as your body's deprived of oxygen, you start producing waste products and acids, and you get inflammatory responses that cause your capillaries to dilate, right? Because that's what inflammation is leaky capillary beds that let fluid out of them. So you're going to become even more inflamed, which is going to take more fluid out of your vasculature and worsen the issue. And eventually, you will start dropping your pressure to your brain and your coronary arteries. And those are the two organs that we just cannot, even for a minute, live without suffering serious consequences. Or you have a few minutes, but not many. So when those start to drop, that's when you start seeing, decreased level of consciousness, and when the coronary arteries don't have enough pressure in them, now the heart's not getting oxygen, which is going to drop your pressure even further. And you can kind of see where this vicious cycle we've got ourselves in. It just goes around and around and around, which causes anaerobic metabolism diffusely, which is going to create more acid. That's what happens when there's no oxygen being delivered to your tissues, right? And means without, and aerobic means with air, but in this context we mean with oxygen. So metabolism without oxygen creates even more acid, which pushes us back into the cycle we've already talked about. And then your body continues to dump even more of these catecholamines to try to hang on. And that works up to a point, but there is such thing as the point of no return without correcting the underlying issue. Because ultimately what these are going to do is they make the heart try to beat harder and try to beat faster, which consumes even more oxygen than under normal circumstances, and that's oxygen it doesn't have. So that'll exacerbate the cardiac damage. And you see how we just got ourselves right back up to the top of this list. So this really is just one gigantic cycle that if you cannot treat the underlying cause of shock, it will end up killing your patient. So that is why when you see somebody who is obviously shocky, rapid recognition and appropriate prompt emergent treatment is critical. Because once they get into that loop, it is very hard to pull them out of it. So we've already hit on this, that there is a pecking order of organs that the body will shunt blood to, right? It's going to take away from the skin first, and then it's going to take away from the skeletal muscle, and then it's going to take away from the gut, and then it'll take away from the liver and the kidneys, and finally, the last two dominoes to fall are going to be the brain and the heart. But the body shuts down in order of, in reverse order of, vital necessity to ensure everything is meant to keep the brain and the heart going, and then the liver and the kidneys just behind that. So this is just more discussion of what's happening actually at the capillary level and how we get into that system again. So I don't think we need to hit on this too hard. Just recognize that anaerobic metabolism leads to acidosis, which when the pH becomes so deranged, the pumps that manage the ion concentrations required for things like stable heartbeat and stable heart rhythm and actually regulating the tone of those capillary muscles, which involve sodium and potassium ions, those become dysfunctional as the pH, the local pH, starts to change. So when those dilate and you lose even more pressure, you're going to have worsening ischemia, and then we're right back in it. So more bad stuff that happens when you're in a hypoperfusion state. The fluid shifting, where you've got this fluid coming out of the capillaries, can cause through mechanisms that are not important to this class, but you end up with the release of lysosomal enzymes. So your lysozymes will rupture within the cells, and these are normally there to defend against bacterial invaders. But when they rupture in your cells that aren't under attack by a foreign pathogen, they cause cell damage, which can cause even further inflammation and breakdown of cellular function. That lactic acid builds up, the CO2 starts to build up, and that acidic environment serves as a vasodilator. And the white blood cells and the clotting system, you start having suppression of your body's normal repair mechanisms, and things get regulated in very inappropriate ways. So your white blood cells initiate, massive inflammatory cascades, that worsen the problem, and then the blood clotting, sensing all of this cell damage, right? You start to form all kinds of little micro clots all over the place. So we call that disseminated for all over the place, intravascular within the blood vessels, coagulation, right? So all these excessively leaky capillaries with all this cell damage around it serve as sites for blood clots to start forming, and you end up with a big upregulation overall, right? If you've got a whole bunch of little tiny clots forming, all over the place, you've got this systemic clotting cascade happening, right? They're all sending out their chemical messengers saying, hey, clot here, clot here, clot here, and that signal propagates. You end up with widespread vascular clotting, which goes back to impeding the flow through those capillary beds. So even if you start reversing the shock, now all of your capillaries are obstructed with these tiny microvascular clots, and continuing badness ensues. So what happens when you start getting this system-wide, failure of blood vessels to stay closed, a propagating inflammatory cascade, and then potentially propagating coagulation cascade, right? You end up plugging up the circulation or decreasing circulation further in organs all over the body. So you'll hear multi-organ dysfunction syndrome. Sometimes you'll see just MODS. Some services, some protocols will ask you to calculate a MOD score, so a multi-organ dysfunction score for your patient. We're not going to go into that right now, but just be aware that there's different scales for scoring this, and some systems want you to do that and make it part of your report. So when this coagulation or this perfusion breakdown starts happening in multiple organs, you end up with multi-organs in states of dysfunction. And when you start getting major organs shutting down, that whole inflammatory cascade, everything comes back to this inflammatory cascade. This is what ends up killing people, causing, even if you are able to turn them around, this organ damage will still persist and could end up killing them, days or weeks later, causing permanent disability. So you get all kinds. These are just various immune system arms that will get upregulated, right? So the complement system is just a way for your body to destroy dead, defective, or infected cells, but that starts getting activated regarding your body's own cells because they're all dying. So your immune system says, well, these cells are on their way out the door, let's get rid of them, even though they're not dying from a disease or an invading organism. It's from lack of perfusion, but your immune system starts destroying them anyway. We talked about the coagulation system. Then you get bradykinin release, which causes even worse vasodilation. When we talk about certain medications causing angioedema, non-allergenic angioedema, right? So people get the tongue and the lips swelling, but it's not an anaphylactic reaction. That's through a mechanism regulated by bradykinin. So you get all of these systems activated that perpetuate the cycle. So how do we know somebody's in MODS? Without getting labs, it's hard to know exactly which organs are shutting down, but a MODS patient, you'll never forget it when you actually see it, when you see somebody in late stage shock. Obviously, they're going to have low blood pressure. They're going to not be perfusing the vast majority of their tissue, so they're going to be cold. They're going to be confused. You go to stick an IV in them and they just bleed and they bleed and they bleed. And that comes from your body has exhausted all the clotting factors, right? You have a fixed amount of platelets and a fixed amount of clotting factors. And when you get into that disseminated intravascular coagulation, there's nothing left to actually clot off, a traumatic bleed, or to stop the bleeding from sort of the normal wear and tear injuries that the body normally handles on its own. So they could be having, nosebleeds or bleeding from the gums, or you go to stick an IV in them and it just doesn't stop bleeding. You'll see, lab changes that reflect whichever organs are failing. Tissue acidosis, so their blood gas, these are the patients whose blood gases are going to be, 7.0, 6.9 on their pH. Their bicarb will be almost non-existent. The CO2, it can, depending on how their respiratory status is doing, can go either way. But if they're starting to build up CO2 because they're not able to breathe effectively, obviously they're very, very late in the game. And then all of that's going to come together to inhibit metabolism. So you're going to have diminished, cognitive abilities. You could have sensory deficits. Nothing is going to be processing energy correctly because it's not getting oxygen. The low flow is not bringing glucose. So they will look like they are shutting down, and that's because they are. And then sort of the last of all of that we just went through is the sort of the microvascular shock. We talked about the container problems, the problems that can happen in the blood, the problems that can happen within the vessels themselves. Cardiogenic shock, pump problems, has its own section coming up, so it's not included in this pathophys preamble right here. But it is worth noting that you can have good pump function, you can have good container function, and still end up initiating that shock cascade that culminates in multi-organ dysfunction secondary to a respiratory insufficiency, right? You can cycle all the blood you want, but if you're not able to get oxygen from the lungs into the blood, it's all, there's no point in any of it. You're going to end up in the same place. No oxygen begets lactic acidosis, which will start to cause vasodilation, which once you start getting that profound vasodilation, it's all over. So respiratory failure can be a pathway into the shock cascades, whether that's from direct lung issues like a pneumonia or pulmonary edema. Although if you're getting that, there's probably a pump problem unless it's a non-cardiogenic pulmonary edema stemming from an infection or an injury or sepsis from some other part of the body. But again, if that's happening, there's a little bit of a chicken and the egg thing here. What starts it is only relevant so that you can recognize that it's starting and be able to stop it. But once, whether it's the respiratory side that starts it or the metabolic side that starts it, it will drag the other part in with it if it's not fixed. So, other things that can cause the respiratory side insufficiency can be things like cyanide poisoning. So cyanide prevents the body's cells from using oxygen to accept the electron in the electron transport chain, which prevents them from making ATP. So they end up not being able to produce energy to continue their vital functions, or carbon monoxide, so CO, 1O, carbon monoxide binds to hemoglobin and holds onto it far, far, far better than oxygen does. So it'll bind up all of those hemoglobin sites, and now the red blood cells can't carry any oxygen. Or you can have anemia, which is where you just straight up don't have enough red blood cells to carry oxygen. So these are ways in which the respiratory side of things can get you into this shock cascade. So we've already hit on, I said pump failure is going to be its own thing. Low fluid volume can lead you into that pathological cascade, right? Because not enough fluid in the tank is going to cause you to not have enough to cycle. Or if you've got big, giant, leaky blood vessels, even with a normal amount of fluid, you're not going to be able to generate pressure, and you end up back in the pathological cascade. But this right here, these are the three. I know everything we just went over is complicated and new and scary. The nuts and bolts, like what do I need to know to save the patient right in front of me who looks like crap? You've got to figure out which one of these three things they fit into, and then do what you can to treat that. So is it a pump problem, a fluid problem, or a tank problem? Because any one of these can set off that entire cascade and will end up causing the other two. So you better you got to put the fire out when there's only one. And you need to be on the lookout for this, right? And if you get a trauma patient that makes you pucker a little bit when you see him, makes you want to throw up, makes you scared a little bit as a provider, or you cringe when you see it, be on the lookout for signs of shock, right? This is why we have to keep them warm. This is why you want to get those IVs in. Fluid is appropriate. Let the hospital know what's happening. They have so many resources, but they've got to know you're coming and how bad your patient needs them. Any major abdominal or chest injury, right? A massive chest injury can damage the lungs or can damage the heart, which are two absolutely vital components to keeping somebody out of shock. Then your abdominal cavity is just full of things that bleed, right? Any bleeding injury to anything in your abdominal cavity, you can lose a ton of blood into that cavity, and you'll have no external symptoms until you're looking at a patient. Why are you pale? Why is your heart rate 140? Do you have a pulse? I don't know. Anybody with a spinal injury should raise your index of suspicion, right? If they've got motor or sensory deficits after an injury to the spine, you need to be on the lookout for shock, and we're going to get to that mechanism, right? But you're seeing a pattern here, right? Anything high mechanism as far as injury goes, shock can come as a result. And then on the medical end of things, severe infection. So that's going to be, they get UTIs all the time, but now we can't really wake them up. They've had this really awful fever. They're confused. They're lethargic. They're breathing 30 times a minute. We can't find a blood pressure on them. Sepsis will cause this. Major heart attack, right? That's going to knock your pump out. So if you get that patient who's got the crushing 10 out of 10 chest pain, feel like they can't catch their breath, elephant sitting on their chest, just because their pressure's up when you find them does not mean it is going to stay that way. These patients will turn, and they will turn quickly, and that is why rapid transport or paramedic intercept, not that paramedics can fix the heart attack, we just have a few more toys at our disposal to keep them from going over the cliff a little bit longer. But when we push rapid transport, it's because we're trying to stop this cycle from starting in the first place, right? And the only way you're going to stop that heart attack patient is to get them to a cath lab. Then obviously major anaphylaxis, right? Somebody who's truly anaphylactic, airway involvement, hypotensive, decreased cardiac function, anaphylactic shock, like it's in the name. So you've got some high mechanism traumas and some high mechanism medical cases that you need to be on high alert for signs of shock and get out in front of them as early as possible. All right, so now let's start getting into the specific causes and what we're going to do about them. So with our big broad strokes brush, we're going to say there's 4 categories of shock: distributive, obstructive, cardiogenic, and hypovolemic. So distributive, this is going to be a tank problem, right? Or something with the vessels. Bypass obstructive here for just a second. This is a pump problem, cardiogenic, right? Because that's going to be the heart. And then hypovolemic is going to be a fluid problem. And then obstructive can cause cardiogenic. It can end up looking like a distributive, but it's kind of its own thing. Fortunately, it is, out of all of them, the easiest physiologically to understand. So there's not one specific thing, but what it does is very specific and not at all complicated. So distributive, you've got a tank issue. Cardiogenic, you've got a pump issue. Hypovolemic, you've got a fluid issue. So you can see, if this is your normal patient right here, this is your hypovolemic patient. The balloon is not damaged. There's just not enough air in it. So distributive is, this is your normal blood vessel right here, and this is your blood vessel in distributive shock, right? So your container has enlarged. You've got the same amount of fluid now in a much bigger container, and that's going to drop your pressure. Cardiogenic is exactly what it sounds like, right? Cardio is heart, genic is starting or beginning of. So cardiogenic is this problem is with the heart itself, right? You've got a problem pumping the blood. And then obstructive shock is exactly what it sounds like. There is something blocking blood flow. You have a physical obstruction to blood flow. Whether that's a massive blood clot causing a pulmonary embolism, or a tension pneumothorax that is obstructing venous return, that is obstructing cardiac filling, that is obstructive shock. That's probably the easiest to conceptualize out of all of these. And if you want to know, if you really want to troubleshoot, where is this problem? Can of shrimp is my way of keeping track of all the, when I've got that person in front of me, it's like, hey, you look like crap and nobody's telling me anything about you. Here's the quick rundown of where you need to look for problems. So here's our 4 major classes of shock over here, and I have color coded these to try to help you keep track of which one can cause which. Not 100% foolproof, but this is the way my brain works. If it doesn't help you, forget about the colors. But you can have cardiogenic, which is, again, pump failure, heart failure, anaphylactic. You all know what that is. Neurogenic is where those spinal injuries come in, and that's where you've got a failure of the nerves of the sympathetic system to maintain appropriate hemostasis. Again, obstructive shock is its own thing, very distinct category. Septic shock is from the massive infection, and so that's going to cause a distribution problem, right? It's going to dilate all of your blood vessels. You're going to dump fluid, into the intravascular space. It's not leaving the body. They're not hypovolemic. The fluid is there. It's just in the wrong place. So we call that a distributive shock. Vessels are big. You've got a tank problem. Hemorrhagic is going to be what causes your hypovolemic shock. Then respiratory and insulin don't necessarily fit the 4 categories, but these are the offshoots that will feed you into this cycle, on their own merits, right? Respiratory, there's no oxygen. We've talked about how that gets you into this cycle. And then insulin shock is where there's way too much insulin on board. and there's no, right, their blood sugar drops to the point where they don't have enough circulating sugar to produce energy. And here we are, when your cells can't produce energy, they can't maintain vascular tone, you get dilation, everything goes to hell. So metabolic shock is, can be the result of any of the, three non-obstructive shock types, but that's going to be somebody who's in like profound DKA or certain poisonings where they're not appropriately metabolizing glucose, they're not appropriately utilizing oxygen, and it's resulting in that acidosis that can cause vasodilation, that will cause heart failure, that can cause them to lose fluid through urination. So metabolic shock can cause any of the three, broad categories of shock. And then psychogenic is the last one, and that's the patient who gets really surprised or startled or scared and then just collapses, right? They have a psych-related shock induced, and these are typically transient, but they do dump their blood pressure, their heart does cease to function the way that it should, and they have a transient shock state until everything resets and comes back online. So getting into the four sort of broader categories, specifics to each of them. Hypovolemic is exactly what it sounds like. There is not enough blood in the body. And again, this is not going to be due to inflammation, right? Those patients that are in distributive shock with the big giant leaky blood vessels and all the fluid leaking out of them, it's still staying within the body. They do not have a low amount of fluid. It is just in the wrong place. Hypovolemic shock is Elvis has left the building. The fluid is not here anymore. It will need to be replaced, not reallocated. So could be due to blood loss, but it could also be due to things like DKA, where the blood sugar gets so crazy high that these patients urinate excessively and end up losing, water volume. I mean, these people can end up being 8, 9, 10, 11, even 12 liters of fluid down from where they should be because they pee it all off. All right, so you can have hemorrhagic, you can have non-hemorrhagic causes of hypovolemic shock. Vomiting and diarrhea are going to be another one where the fluid has left the body and now they don't have enough of it. So places you can lose fluid other than bleeding, talking about vomiting and diarrhea, sweating. You'll see this if you've got an athlete who is not getting enough breaks, drinking enough water. It is possible to sweat too much of your fluid out and end up fluid down. So by internal losses here, it's worth clarifying that this is different than the interstitial fluid that happens with vasodilation. These internal losses are where you're going to see things like ascites, right, where the fluid is accumulating in a body cavity and it cannot get back into the vascular space, right? These patients who are vasodilated and who dump fluid into the interstitial space, we can get that fluid back. But if you've ever seen somebody have to have their abdomen tapped to drain fluid out of it or get, their GI tract drained, that fluid cannot get back into the vasculature. So that's where the internal losses come in when we talk about dehydration, hypovolemic shock. And then you can straight up lose plasma from burns and external wounds, right? If you guys have ever gotten like a road rash or a bad burn, that top layer of skin is responsible for keeping all that interstitial fluid in the body where it can get reabsorbed by the vasculature, right? We talked about that microvascular circulation back in the physiology lecture. But if you lose your skin, that top layer of skin, that fluid is just free to leave the body and will run off. So that's why keeping burn patients hydrated, getting them IV fluids on board early and relatively often, if it's a severe burn, is important, because they will just lose plasma. And that's what you see when you see the liquid runoff, that clear, just slightly tinged liquid that runs off of a bad scrape or a burn. That's plasma that should stay in the interstitial space to get reabsorbed, leaving the body. So that can certainly cause hypovolemia. Diabetes insipidus is a problem where your body does not produce antidiuretic hormone or does not respond to antidiuretic hormone, which causes your kidneys to just dump all of the water into your urine inappropriately. And then that osmotic diuresis is what we talk about with DKA, where there's just a ton of buildup of sugar in the vasculature, gets filtered out in your kidneys, which pulls all the water to it, and they end up peeing it off. So these are the ways in which you can end up hypovolemic other than hemorrhage. Recognizing shock early is important. It's critical patients are rarely pleasant patients, and it's not because they aren't pleasant people, it's because they're sick. Right? Your body becomes very distressed when it is not getting enough oxygen, when it is not getting enough nutrients. The buildup of acids within the body is both uncomfortable and can cloud thought and cloud judgment. So when you've got somebody who tells you, no, I'm fine, but they're a little pale, their heart rate's a little bit up, and they can't sit still, something just seems off about them, they appear anxious despite what they're telling you, right? That's the patient you need to push to let you examine them, make sure you get a good history, good set of vitals. Excessive thirst, plus minus, some shock states come on too quick for that. Other ones, that's a hallmark of somebody in DKA, is they just can't drink enough water. Pale comes first, clammy comes second, cold comes third, right? So as that peripheral vasculature starts to constrict, you get less blood flow to the skin, so that makes them pale. The continuous dumping of epinephrine and norepinephrine will make them sweat, and then ultimately that leads to, right, the sweating cools them off. The lack of blood flow will also make them cool, so they end up with these very, very cold extremities. Their skin ends up feeling cold. Tachycardia comes early on. So the patient that scares me is the one who's got an increased respiratory rate. They're a little bit anxious, and they look pale, especially like their fingers, their nail beds just look pale. Their hands, you go to check their pulse and you notice that their wrist and their hands are just cold, a little slimy from the sweat. Listen to them, but also recognize that they're in trouble. And then obviously blood pressure is the last thing to go. If you wait until they're hypotensive to diagnose them with shock or to recognize shock, they're already, that ship is long gone, right? Because the body compensates. The last thing it wants to let go of is that blood pressure. So do not wait for hypotension to recognize shock in your patients. All right, as promised, on to cardiogenic shock. So we talked a little bit about pulmonary edema in the respiratory unit. This is how that fluid actually gets there. So as the name would imply, cardiogenic shock is failure of the heart. It is shock originating with the heart itself. The heart is unable to maintain output, thus triggering a shock patient, shock response. So a couple concepts to think about here. We've got preload and afterload. And the preload is the load prior to the heart, right? Pre-cardiac is your preload. So it's going to be the resting pressure in the vessels on their return to the heart, right? So preload is what's going to drive cardiac filling from the body. Afterload is the load or the pressure on the heart. Get a different color here. So the afterload is the pressure after the heart. And why that's important is the heart has to squeeze harder than the afterload to generate forward flow, right? So if there's, 100 millimeters of mercury worth of pressure in the aorta prior to the heart beating, right? If the heart doesn't beat at 100 millimeters of mercury, as soon as that valve opens, blood's going to get forced back into the heart. The heart has to make a pressure higher than the afterload to generate forward flow. So, with more afterload, the heart has to work harder. Well, what would cause more afterload? All right, we talked about how our catecholamines, our epinephrine and our norepinephrine, the sympathetic nervous system, when it's stressed, causes vasoconstriction. So if you have the same amount of fluid and you shrink the container size, we shrink down all of those arterioles, you're going to drive more pressure back into the larger vessels, making it harder for flow to go forward, and you essentially increase the afterload. So as a patient starts to go into shock, the body's attempt to maintain blood pressure actually causes an increase in afterload, which if your patient has a normally functioning heart is fine. That increases flow to the vital organs. But in a patient with a sick heart, you actually increase the amount of pressure that heart has to work against. And what you end up with is a heart that is unable to squeeze effectively, and you get pushed back into the heart. And what happens when you get pushed back into the heart is you get pushed back, and if it's into the left heart, you get pushed back into the pulmonary veins, right? And we talked about that micro circulatory level, right? If you've got your capillary beds in the lungs, the hydrostatic pressure should be greater in the arterial side and drive blood forward, and then the osmotic pressure should be greater on the venous side and pull fluid back in to get pumped along. But now we've got this back pressure from a failing heart, which increases the pressure on the venous side, which makes it so fluid can't get back into the capillaries. And where does it build up? Right here in the lungs. It starts by filling the interstitial space, and then will eventually force its way. Remember, this is a very, very thin one cell layer thick, so it's not hard for the fluid to get out of the interstitial space and start to fill up the lungs. So what ends up happening, I told you during the general respiratory lecture and then earlier in this one that the primary cause of right-sided heart failure is left-sided heart failure. And the reason that happens is the left side typically ends up, if somebody has untreated hypertension, right? Their peripheral vasculature stays clamped down all the time, and they've got this high afterload all the time, and the left heart gets thick and stiff and tired and unable to beat effectively. So you end up with left-sided heart failure. So you end up driving all this extra pressure back through the lungs, which makes the right heart have to beat harder to overcome that, right? So now for the right heart to actually drive flow this way, it has to work even harder than it would at baseline, meaning that over time, the right side is going to become thick and stiff and weak. And when the right side backs up, clear some of this out for you, right? So now we're getting this pushback from the lungs, and it's coming back into the right ventricle, which causes backup into the vena cava. Remember, the vena cava is supposed to be low pressure, but with a failing right heart and the weight of the failing left heart pushing against it, now you end up with fluid trapped in your vena cava, essentially flowing backwards. And you end up, same thing with the lungs, how you end up with high pressure on the venous end of the capillaries. Well, now that happens in the peripheral system instead of in the lungs, and you end up with all of this edema here, or in the jugular veins. That's why we talk about jugular vein distension in heart failure. So these are CHF feet. Try to get you a picture of JVD. There's not one on this slide right now, but I will be sure to add one for you. But anyway, right heart fails and backs up to the body. Left heart fails and it backs up to the lungs. Chronic backing up into the lungs makes the right side work harder, and so it will fail following the left. And there are some things that will cause the right to fail first. If somebody has pulmonary hypertension, right, where the pulmonary artery has chronic constriction, or it's too small, or you've got COPD and you've got chronic inflammation in the lungs, and you've got this high pressure in the lungs all the time, that can make the right heart fail first. So it is possible to have right failure without left, but the typical progression is left fails, backs up to the right, right fails, backs up to the body. And that's why you get signs when somebody's having a bad exacerbation and they're at the point in their life where they're having these severe exacerbations. Both sides have typically been affected, and you get the peripheral edema, the JVD, along with the wet, crackly lungs, and the things we typically associate with CHF exacerbation. So obstructive shock is super easy, right? You either get, let's say somebody's got a big blood clot in their calf because they're taking estrogen pills, they sat on an airplane for 12 hours, didn't move, got up and tried to go for a jog or something, broke a big hunk off the clot in their leg. All right, so that clot's going to come up the vena cava into the right heart, through the right atrium, get kicked out of the right ventricle, and it is going to sit. If it sits right here, we call that a saddle embolus, and those are typically pretty fatal pretty quickly. More often than not, that clot's going to lodge somewhere in here, and it just physically blocks the flow of blood, right? It obstructs the flow of blood. Other things that can happen, right, if somebody has a massive pneumothorax and you get a huge buildup of air, right, that compresses this lung so it can't function. You lose all of this function when that lung can't expand. It eventually gets so big that you start pushing on the heart so it can't fill. The pressure starts compressing the vena cava. Now you've obstructed flow, you've obstructed oxygen, you've obstructed flow, and you've obstructed contraction. Everything is bad when that happens. Then cardiac tamponade. All right, so you've got your pericardial sac that normally hugs the heart real tight, but somebody who's having a tamponade, right, ends up with fluid. Could be blood from an injury, could be fluid from an infection, right? But fluid ends up collecting in here, and it ends up pushing on the heart, physically obstructing the heart from contracting or from filling effectively, right? So the heart tries to fill, it doesn't fill all the way. When it contracts, more fluid fills the space and compresses it more. So it's this sort of boa constrictor type deal, right? Where every time an animal takes a breath out when it's caught by the boa squeezes a little bit tighter, so the animal gets less air in the next time it takes a breath. That's how a cardiac tamponade ends up being fatal. And it's really, really important for you all to recognize that this is mechanical obstruction of the heart that causes this, right? Or mechanical obstruction of the blood flow. And the reason I tell you that is somebody who's having a heart attack, and we'll get to this in just a minute, right? They have a clot in a coronary artery. That is a local obstructive shock. That causes the myocardium to experience obstructive shock. But when the whole heart starts to fail because of that clot, that causes a systemic cardiogenic shock. That individual clot in the the coronary artery is not obstructive shock with regards to the whole body. So somebody who's having a heart attack and is hypotensive and otherwise crappy, that is cardiogenic shock. It is secondary to an obstruction. That is true. But the overall shock state of the body is because of the failing of the heart. So it is a cardiogenic shock. For system-wide obstructive shock, right, it's got to be one of these things that's the actual obstruction is what's causing the systemic shock state. So distributive shock is secondary to widespread dilation of typically the microvasculature, right? So it's not like your radial artery is going to massively dilate, but the arterioles, under all of the skin in your arm and your hands and your fingers, right, that can all dilate. Your femoral artery will not become massively dilated, but it's all the little capillary beds, and the arterioles that end up coming off of those major arteries that end up dilating, right? Because if a massive artery dilated, there's still not a ton of surface area. You're not going to get a huge increase in container size from just one large vessel dilating. But when you have hundreds of thousands and millions of capillary beds that all dilate together, that's where you lose significant amounts of pressure. So we talked about the inflammation cascade, and how acid buildup and CO2 buildup, how the immune response all feed into this dilation, and you just end up with the same amount of fluid in, right? So, right, we've got fluid, and I'll make blood's red. Right, so under normal circumstances, this would be all full of blood, but now that it's dilated, there's only, there's that much blood in it relative to the size of the vessel, so that's obviously going to decrease your flow. So when that happens all over the body, we call that a distributive shock. The pressure has been distributed inappropriately. So neurogenic shock, this is a flavor of distributive shock, but this is why spinal injuries, especially high spinal injuries, are so concerning for shock states, right? So the sympathetic nervous system hits all of those, arterial, smooth muscle sphincters that control the pressure in them, control their size. So if you have an injury to that spinal cord, the body will lose the ability to maintain that tone, right? I said the parasympathetic system kind of runs in the background all the time, and then your body modulates the sympathetic system as needed. So if you lose the sympathetic system, you end up with a predominant parasympathetic system and no vascular tone. You lose all that vascular tone. So you end up with a distributive shock below the level of the injury. And if the injury is high enough, right, so right, this is our brain up here, and this is the spinal cord right here. So your heart is innervated by the sympathetic nervous system with nerves that branch out from T1 through T5. So if you have an injury at or above one of these, the first 5 thoracic vertebrae, your body loses the ability to regulate cardiac function. So the difference with neurogenic shock, right, in a normal distributive shock, right, you have all your compensatory mechanisms in place. So you have your septic patient who's going into shock. You would expect to have high cardiac output to try to compensate for that, right? Squeeze harder, squeeze faster. But in a neurogenic shock patient, you end up with that poor vascular tone and no ability to regulate heart rate or force of contraction. So if you've got a spinal, this is the classic, and these patients are real. They're at the med all the time, typically after holiday weekends where people dive into shallow water head first. And these will show up on your exams all the time, right? They'll tell you, what kind of shock is this? And they'll give you, somebody who's hypotensive, but their skin will be warm and their heart rate will be normal or slow. That's the hallmark of neurogenic shock, right? Because they vasodilate and their heart cannot do anything about it. They don't have sympathetic tone below the level of the injury, so they cannot vasoconstrict anywhere to try to compensate, right? So under normal shock conditions, in a normal distributive shock, you would expect epinephrine and norepinephrine to start kicking in and start trying to shunt blood towards the middle of the body, and you'd end up with like the cold fingers and the cold toes. But you can't have that with bad neurogenic shock, right? So they're hypotensive with a normal to slow heart rate and warm extremities. So anaphylactic, another major distributive shock, bad allergic reaction, vasodilation. This, shouldn't be anything new. Now you all understand why increased permeability and overactive immune stimulation further contributes to the shock. And you also end up with bronchoconstriction, this immune-mediated bronchoconstriction. So anaphylactic shock starts out as a distributive shock, but it can very quickly turn into a respiratory shock, and there's also some direct cardiosuppressive effects, secondary to some of the inflammatory and immune mediators release, so you end up losing force of contraction. So your distributive shock can turn into respiratory, can turn into cardiogenic, but classically we would say anaphylactic shock is a distributive shock. Septic shock is from infections, immune mediated. We've already gone over why that's bad. And psychogenic shock is from a transient surge in parasympathetic activity, right? So somebody becomes startled or receives really bad news and faints. That's psychogenic shock. It's a sudden loss of their vascular tone that drops their blood pressure. They lose consciousness. You have to be aware, make sure they didn't hit their head on anything dangerous. Consider spinal precautions until you can get a good exam on them. But once they are unconscious, everything will typically reset itself, and they will return to normal thereafter. So how do we progress through shock? So two broad categories, and there's some more specifics down uh, each of these roads. But so compensated shock means the body is hanging on. It is able to maintain adequate perfusion despite something that's starting to cause a shock reaction. So that's where you're going to get this autonomic sympathetic tone, right? Their heart rate's going to increase, their respiratory rate's going to increase, their peripheral vasculature is going to start to clamp down. But you go to take a blood pressure on them and it's normal, right? You draw labs on them and they're pretty normal. No organ damage yet. Their systolic will be okay. Their diastolic could be fine, could be a little bit low, right? If it's a distributive shock and there's not enough fluid in the tank, that resting pressure is going to be low. But with a good hard squeeze from the heart, and some very peripheral vasoconstriction, you can get that systolic pressure back up. And then they go over the edge and they decompensate. And this is late. If it's hemorrhagic, they're down 30% or more of their blood, right? They're past the point where that auto transfusion effect can rope them back in. Their compensatory mechanisms are starting to fail, right? So you look over here and you start to see altered mental status, true hypotension, trouble breathing, whether that's from the pulmonary edema that's starting to set in, or they're not getting enough flow through the lungs to pick up enough oxygen. They start to look really bad, right? They have that white, almost marbled look to them. Weak or absent pulses. So these are all your signs of decreased or decompensated shock. And physiologically, we talk about multi-organ failing. So when you start seeing poor urinary output, right, their kidneys are no longer filtering appropriately. There's not enough fluid for them to make urine, which is going to cause the accumulation of toxins when the kidneys can't clear them because there's no fluid to excrete off. So this is where we start to see that MODS come into play. And then irreversible is when they're gone. They are not perfusing anything meaningful at this point. And if they do have central pulses, it's not doing anything other than, very weakly pushing blood past the point where you're feeling it, but it's not doing anything productive at the end organ, which means that ultimately you're not going to have any fluid coming back to the heart, and that pulse is going to stop and stop soon. So irreversible is terminal stage. So what do we do about shock? There's the obvious stuff. If they're bleeding, you need to stop that. You need to do that first and do that quickly. Shock positioning is not really a thing. We used to teach, put them in Trendelenburg and put their legs up. It'll dump fluid back to their core. The body can do that on its own. Right? It'll clamp down your peripheral vasculature really, really, really tightly. And if you tip them up like that, you're just going to cause the fluid to redistribute poorly in the top half of their body if they're profoundly dilated beneath the superficial levels of the skin where that vasoconstriction is going to have its effect. So follow your local protocols. Typically it's position of comfort. You don't want to compromise their respiratory drive or effort by laying somebody down who can't breathe while they're laying down. Keeping them warm is huge. We'll talk about this in trauma, but cold patients have problems with blood clotting. So if they've got that DIC, they've exhausted their coagulation factors and they're bleeding somewhere internally and they can't stop it. Making them cold will make it even less likely that they'll be able to stop bleeding from, sort of the normal wear and tear injuries. And obviously, if they start bleeding, they're just going to lose more blood volume, and that will worsen their shock state. IV fluids follow local protocols. For you guys, you're going to give 20 cc's per kilogram, preferably of lactated ringers. There's some major problems with normal saline, but it's also a trade-off because those fluids, even if you warm them, are going to be colder than the internal body temp, right? Even if you put them on your dash and run the heat and you get that bag up to 80 degrees Fahrenheit, that is still, right, 80 degrees in the human body is severely hypothermic. But in the short course, as long as these patients' lungs aren't flooded with fluid from cardiogenic shock, even a transient bump in their blood pressure, regardless of whatever other issues it causes, is important for maintaining vital organ function. Long ago, far away, and by that I mean like 5 to 10 years ago, EMS would throw fluids at people until they had a normal blood pressure. And your exams are going to ask you to give fluid, until you get distal pulses back. The classic textbook answer is until you get a systolic of 90 or a MAP of 65. So that's the target. And if you can do that, with 1 or 2 fluid boluses, that's great. And that's what you need to put on your test. Leaving testing land and into the real world, anything past, a bag or 2 bags of fluid, right, they've got to distribute, unless it's a hemorrhagic or a fluid loss patient, right, if it's a distributive shock patient, that once you fix the blood vessels by giving them things like paramedics or doctors giving them vasopressors, that fluid's got to go somewhere. And they'll end up having way, way too much, and we'll end up with pulmonary edema, and it causes issues on down the road. So on your test, and honestly in the real world right now, your 20 cc per kg bolus targeting return of radial pulses is wonderful. Keep an eye on the guidance as you go through your career, because we're only just now starting to wrap our heads around the potential damage caused by blasting our patients with fluid until we have a number on the monitor that we like, regardless of whether it's actually good for them or not. And if it is a trauma patient or an acute process causing it, like a heart attack, you want to get them to definitive care within the first hour. Their likelihood of survival, especially in trauma, goes up by orders of magnitude if you can get them to definitive care within an hour of onset of the injury. And then all the other stuff, guys, this is no different than you would do for anything else, right? It's ABC management. When you find a problem, you fix it, you stop what you're doing on your sheet, you fix that problem, and then do your OODA loop and come back, and then troubleshoot the next one. So airway, oxygenate as needed. If it's somebody who you anticipate will require intubation, right, or they're heading into a respiratory shock, high flow is great. Otherwise, we want to just titrate to our 94%. And the reason for that is oxygen is highly reactive and can cause tissue damage. So over-oxygenating somebody who's in an inflammatory state can actually worsen their shock state. Position of comfort, right? You don't want to agitate them or make them any more uncomfortable than they already are. That makes their heart work even harder. We want to minimize further strain on the body and try to give them an optimal environment to focus on staying alive. Get your vitals, let the hospital know what they are. Fluid bolus, caution here, don't delay transport to get your line and to give fluid, right? That bag of fluid ain't going to save their life. The antibiotics will, the vasopressors will, and you all can do that on the way. You all can get that line and start the fluid on the way to the hospital. Cannot stress this enough, guys. Keep them warm. You'll learn in paramedic again about the relationship between hemoglobin and plasma oxygen levels, and cold patients don't do well in that regard. You impair oxygen delivery the colder they get. So even if you do everything else right and you keep them cold, those red blood cells won't let go of the oxygen, and badness follows. So even if you're not planning on giving patient fluid, or you don't think you have time to start the line and give fluid, right, or it's a cardiogenic shock patient, their lungs are super wet, you don't want to give them fluid, get that line in. The hospitals will use them, right, especially if your patient emergently needs blood or needs a quick shot of vasopressor to stay alive, or they code. Having that line in place is a huge help to the hospital. They're going to start their own. Don't get your feelings hurt when you see them poking and prodding your patient right after you drop them off. But if that patient has a sudden change or needs anything life-saving immediately on arrival, they will use your lines to give it. So don't delay transport. Don't forget to do your ABCs. But if you've got time in transport, you've got them warm, you've got them oxygenated, you've got them comfortable, the hospital knows you're coming, you're 2 minutes out, go ahead and throw that line in them. And it also, if you do have more time, it'll let you start some fluid replacement if that's what you think your patient needs. Again, we need to treat our patients, not the monitor, not the numbers. Hypoperfused patients typically benefit from some fluid. There is a huge debate, and this is raging in the world of EMS and critical care right now, about how much. How much does it take to be helpful, and how much does it take to be harmful? And this is one of those things where you would have thought that after over 100 years of giving people IV fluids, we would know what the therapeutic range is on them, and we just don't. So that's why you have to give your bolus and then reevaluate, right? Recheck their lungs, see if their edema is getting worse. Do they look better? Do they feel better? Targeting numbers is great, but you have to remember to treat your patient and not just what's good for them while you have them, right? Because you could, I could give you, right? I can give all of you, on your deathbed with septic shock, I could run 5 bags of fluid into you and probably get you a viable blood pressure. You would die from pulmonary edema 2 to 3 days later, or hypothermia, or any of the other issues caused by fluid. So your boluses are fine. Just remember, like any intervention, you've got to reassess your patient after you give it. Normal saline is a garbage fluid. There's absolutely nothing normal about it other than the osmolarity. Right? It is isotonic, technically speaking, but it has hyperphysiologic, right? Globally, it is isotonic, right? With the respect to everything in your blood, it is isotonic. However, the sodium in it is way too high, and the chloride is just exorbitantly high, dangerously high. There's absolutely nothing normal about normal saline. And the pH of normal saline is 5 to 5.5, right? So if you've got an acidotic patient, you're trying to bring them, right? You know that they've got a bad metabolic acidosis. Their pH is 7.0, 7.1, 7.2. Dumping a bunch of 5.5 pH fluid into them is not going to help that. And then all the extra chloride causes badness that you learn about in paramedic school. All right, I'm going to get off my soapbox. If you have lactated ringers, you need to use that. If you have normal saline, be especially cautious with it. But with normal saline, only about 250 mils out of your 1 liter will remain in the intravascular space, over the course of even just a few hours. So I said, it's good as an emergent. We have got to get your organs perfused right now. Stop the damage intervention. But just understand that on down the road, it's not how you want to get them to maintain that blood pressure. That's all I'll say about that. On your test in your lab, give the fluid as indicated. Follow local protocols. Just be ready for updates as you go through your career. And that's what I mean by you must support their perfusion. You must support it. But just be aware of what's actually happening. And then, these are your guides for our goals, when giving fluids, right? You want to maintain radial pulses, which, colloquially we say is between 80 and 90 millimeters of mercury for systolic blood pressure. That hasn't really held up to scrutiny. I have felt a radial pulse in somebody, with a BP of 60, and I've had patients with a BP of 140 that I couldn't feel one. So the number is irrelevant, but if you can feel that radial pulse, you know that you're getting good forward flow near the end of an extremity. So it's reasonable to assume that you're getting good blood turnaround. Your preload is sufficient. Your heart is overcoming the afterload. Life is good. Anything with peds is weight-based, and if you're not sure what their weight is, you're going to use this Broslow tape. It is super easy to overbolus a pediatric patient, right? The volumes are very strictly regulated in them. You must weight base. And if you don't know, use the height-based tape to get an estimated weight. Keep checking your patient. And if you've got a hemorrhagic shock patient, understand they're losing blood, not pasta water. And for all intents and purposes, normal saline is pasta water, right? And you guys cook pasta, you sprinkle a little salt in the water, and then you boil it. Congratulations, you've made saline. It might not be the normal, I can't tell you the concentration of how much salt you sprinkle in, but, normal saline is good pasta cooking water. And your patient has lost blood, not pasta water. So they can't oxygenate their tissues if what blood they have left becomes too dilute. So your focus needs to be on stopping the hemorrhage and then supporting their volume within reason. And I'm not going to tell you exactly what that means. Follow local protocols. And the other thing too is we don't want, if somebody's hypotensive from bleeding, we want them to form clots, especially if it's internal bleeding. So if their pressure is 70 or 80 and you've got a decent pulse, with that, if you dump a bunch of extra fluid in, right, you're going to stretch the blood vessels, you're going to increase the cardiac output, you'll raise that pressure. You can dislodge clots that are forming to help them stop bleeding, and you really don't want to do that. So carefully monitor and conservative management with hemorrhagic shock patients. Then if you've got a mom, there is concern about, too much fluid in a pregnant patient, but number one cause of fetal death in emergencies is maternal death. So do what you got to do to save mom, and that's the best thing you can do for that baby. So some shock type specifics, right? We just went over all the general stuff. If the hypovolemic is from bleeding, stop it. At least one 18 gauge, preferably a 16. And I tell you that because an 18 gauge normal length will give you about 105 mils per minute just under gravity in a well-flowing line. A 16 gauge will give you roughly 220. mils per minute. So you over double going from an 18 to a 16. Just for a little perspective, a 20 is about 65 mil per minute. So you're less than double from a 20 to an 18, but you more than double from an 18 to a 16. We can rapidly transfuse blood through an 18, but we can do it twice as fast through a 16. But if you're unsure, having an 18 that's in is better than a blown 16. So again, don't be afraid to try 16s. You need to get good with them because they do help these really sick patients. Guys, then it's just ABCs after that and high flow diesel. Cardiogenic shock, right? Nitroglycerin is a venodilator predominantly. Right? So if we dilate the venous end of things, right, we're preferentially expanding the return to the heart. So that takes the strain, that reduces the pressure, the strain on the right heart, right? Gives more space for stuff to back up into. And then on the left side, when we dilate the pulmonary veins, right, you essentially decrease the pressure in the venous side of things, which will allow for a greater pressure gradient from the arterial to the venous side, so that you enable better forward flow and you diminish, right, because the failure when you've got left heart failure is, right, you're backing up into those veins. So when you dilate them, you decrease the pressure, which will let the right heart more effectively pump against that back pressure in the veins. So nitroglycerin is great, but obviously we don't want to give it unless they've got sufficient blood pressure to do it, because there are some arterial effects and it will dump your preload, as previously mentioned. So nitro when they can tolerate it. But if you've got that bad pulmonary edema patient whose blood pressure is just through the roof, right? They're not actually perfusing their whole body at that pressure. They're just peripheral is clamped down so hard and their heart is straining to beat so hard. They've got massive afterload is what's driving that high blood pressure. So when they're hypertensive and in cardiogenic shock, go ahead and toss that nitro in, relieve the pressure in the pulmonary veins, make the fluid stop backing up into the lungs. You get some arterial dilation, which will reduce the afterload. Everybody's happy. Oxygen to affect CPAP is phenomenal if you're getting that pulmonary edema we've already talked about. If they're normotensive or hypertensive, putting more fluid in is not going to help anything. So fluids are not necessarily your go-to in cardiogenic shock. You actually want to expand the container size when reasonable in these patients. So obstructive shock is just going to be optimizing oxygenation and getting them to the hospital. They need a big old needle put in it. Paramedics can't do it, doctors can. But these are patients where getting them oxygenated ahead of time so that if they go into cardiac arrest, they've got a nice big reservoir of oxygen in their lungs. You can actually do them a favor, right? Their heart's getting really crappy output, so you want to optimize the blood that is flowing by making sure it's well oxygenated. Same thing for tension pneumo, right? You want the part of the lungs that are working and aren't collapsed to be getting as much oxygen as possible to increase that gradient and drive more into the plasma and onto those red blood cells. But ultimately that air's got to get out. Paramedics can do that. So that's one of the times where, arranging an intercept, especially if you're far from the hospital, even if it's a little out of the way, can be beneficial to these patients if they're already showing late signs of shock. They're hypotensive, they're super agitated, they're very, very tachycardic. Meeting up with that medic to get a needle put in it can be extremely helpful. IV fluids are good in these patients because you can increase the vascular pressure, even if it's just transient. That's fine. You want to expand that vena cava as much as you can, increase the preload as much as you can, so that the contraction the heart is getting is optimized. Pulmonary embolus patients, right? If they've got the story, right, the long flight or the bed bound, they've got one leg that's way more red and swollen than the other, came out of nowhere all of a sudden, sharp stabbing pain right in the middle of their chest. They're hypoxic, they're tachycardic, but you hear good air moving in both lungs. That's pulmonary embolus until proven otherwise. These also get some weird presentations, some like crazy altered mental status and hypoxia with like no other signs. These patients need aggressive oxygenation. You can trial them on fluid. Sometimes it helps, sometimes it hurts. Take it slow, take it easy, and make sure you coordinate your care with the receiving facility. Some docs might tell you to try nitroglycerin, some might not. I'm not telling you to do that. This is one of those pathologies that is constantly evolving because we don't have a bulletproof way to manage them. But getting them to a place that can give them thrombolytics or can take them to surgery is going to be important. Septic shock, obviously number one, don't get yourself infected if it's something respiratory that's causing their problems. These patients typically do really well with IV fluids. Just understand, especially if it's an old person with comorbidities, a history of congestive heart failure, you don't just want to blast them with 2 liters of fluid. You want to do your 20 cc's per kg, reassess, right? You might even want to just do 500 and reassess as you go. And again, you're targeting evidence of distal perfusion. So your neurogenic shock. Obviously, they've got a spinal injury, so you're going to want to try to protect that. Immobilize. This is one of the few times that full immobilization may be warranted. If you can get them nice and secure on a scoop stretcher, just strap them down, make sure you've got the head. You can still secure their head on some of the scoop stretchers. That can be more supportive. Follow local guidelines for testing purposes. You want to immobilize them though. Support ABCs. So the expression goes C4 to C5, stay alive. That's because the phrenic nerve, which is the nerve that innervates the diaphragm, exits the spinal cord between C4 and C5. So if you've got a patient with a C4, C5, or C3, how you could have a C2 or C1, those patients typically don't do so hot even before you get there, but we have seen them. So if you've got a spinal injury above the C4, or at the C4, C5 or above, they may well not be able to breathe because they're unable to trigger their diaphragm. So they may need support in that front. You've got to keep them warm because they're going to shed body heat like crazy because their whole peripheral vascular system is going to inappropriately dilate. So they're going to get excessive blood flow to the periphery and they're going to just shed their body heat. So you've got to keep them stabilized, keep them breathing, keep them warm. And if they are hypotensive, support their blood pressure, understanding that you may not see the tachycardia, especially if it's one of those higher T-spine or certainly a C-spine injury, especially a complete transection or a severe injury, you're not going to be able to regulate that heart rate and contractility. So anaphylactic shock, guys, epi, like that is it. Epi is the name of the game. Before you do anything else for your anaphylactic shock patients, you need to hit them with epi. Your national registry sheet's got the A, the B, the C. Sure, put them on oxygen. You're a two-man crew. One person's putting them on oxygen. The other person is getting the epinephrine out. Because giving them oxygen is not going to help them when their throat completely closes or their bronchioles are completely sealed off. Right, so when you're in lab or you're taking your national registry, I will direct my partner to apply high flow oxygen while I draw up epinephrine. In AEMTB, you all did the EpiPens. That is still in your scope. If your patient's got one handy and they're too chicken to use it, you can go ahead and hit them with that. Otherwise, you're going to want to just draw up your intramuscular epinephrine. Do it as soon as you can. And then everything else we're going to talk about on this slide, if you're doing that and it's time for another epinephrine dose and they're still showing signs of anaphylactic shock, you stop what you're doing and you redose that epinephrine. Nothing is going to help them more than that epinephrine. IV and fluids to support blood pressure is fine, but epinephrine will cause them to vasoconstrict, will cause their heart to beat faster and harder. That will also support their blood pressure. Albuterol is absolutely indicated, especially if they're wheezing, but it's a beta agonist, so is epinephrine. You'll get the same effect. Is it reasonable to do both? Absolutely. But epi first, epi often. Everything else is a bonus. Psychogenic shock. Try to get a good story. Make sure that's what it. Do not write it off. There are a lot of old people or even middle-aged people with bad hearts that drop from bad cardiac dysrhythmias that you don't want to write off as being psychogenic shock. So getting a good thorough history, questioning bystanders, and again, did they hit their head on anything when they fell? And then check for any C-spine pain, tenderness, neuromotor deficits when they come to. Respiratory insufficiency, if it's secondary to chest trauma, your book says to seal the hole. That's an evolving concept. So if you see it on the test, yes, you're going to apply the 3-sided dressing and you're going to burp it to let air escape. And that's what I'm going to tell you to do right now, but keep an eye on the literature and the protocols as you go through your career. Anything that is poking through must be stabilized because you do not want to cause any worsening injury underneath. And then, guys, it's ABCs. Make sure they have a good airway. If they need suction, if they need it opened, if they need an adjunct, if they need ventilations, you give that to them. Remember, CPAP is contraindicated in pneumothorax patients. So you would just want to assist their ventilations, but positive pressure ventilation is one of the best things you can do for respiratory failure patients. Now, if their respiratory insufficiency is secondary to pneumonia or pulmonary edema, ARDS of some other ilk, you go right on ahead and you use that CPAP or pop that PEEP valve on your BVM and help them oxygenate, right? Because the only two things that fix hypoxemia from a respiratory standpoint is either increasing the concentration of oxygen, and if that doesn't work, if you're at 100% and they're still hypoxemic, you hit them with the PEEP, either through CPAP or as a valve on your BVM. And with that, we are done with shock. Thanks for sticking with me. See you next time.